Hey guys, in this video we're going to talk about heart block. Heart block is something that most people are exposed to in medical school. We learn the details of all the different types of heart block, but I think that there's a physiologic understanding of the types of heart block and why they matter that sometimes gets missed. So that's what I'd like to focus on today. So what we'll do is we'll go through the different types of heart block, and then we'll talk a little bit more about the physiology underlying them and why that matters for treatment. When it comes to heart block, we categorize things by degree. And as many of you may remember, there are 3 degrees of heart block. There's first degree, second degree, and third degree. First degree is probably the easiest one to start with. Some people will call this first degree AV block. I think a more accurate definition would be first degree AV delay. The reason I think delay is more accurate than block is because in this condition nothing is actually getting blocked, just the atrial impulse is getting a little bit slowed or delayed in order for it to get to the ventricle. On an ECG, this looks like a prolonged PR interval, but otherwise nothing is getting dropped, all the P waves are being conducted. Usually in these cases the PR interval is greater than 200 milliseconds. And that's measured from the beginning of the P wave to the beginning of the QRS, greater than 200 milliseconds. Third degree AV block is also fairly easy to understand. This is when there are 2 things that are present at the same time. One is complete AV dissociation, meaning there's no evidence that the electrical activity in the atria is related to the electrical activity in the ventricles. And you have to have more A's than V's, meaning that the rate of atrial activity is faster than the rate of ventricular activity. If both of these things are present, we call this third degree AV block. In this case, what you'll see on an ECG is essentially P waves marching out at their own rate and QRS complexes marching out at a different rate. If you can imagine here, hypothetically separating out all the P waves, they're going at their own rate, and then here separating out all the QRSs and Ts are going at their own rate. So if you imagine kind of adding these 2 things together, what the real ECG looks like is this. You can see here that in third degree AV block or complete heart block, sometimes the P waves are nice and discrete if they happen to fall away from everything else. And sometimes the P waves are partially visible because they're buried inside the T wave or buried inside the QRS complex, or sometimes they're not invisible at all depending on exactly where they are. Sorry, they're not visible at all depending on where they are. So third degree AV block is complete AV dissociation where nothing is getting through. First degree AV delay is a delay only, and actually there's no AV block, everything is getting through. So then that leaves us with second degree AV block in the middle, which is essentially where some things get through, meaning only some of the atrial complexes are blocked. As many of you may recall, second degree AV block comes in a couple of different types. There's type 1 second degree AV block, Mobitz type 1. In Mobitz type 1 second degree AV block, the PR interval gets progressively longer until a QRS is eventually dropped. As you can see in this case, the PR interval starts relatively normal, then gets longer, and then this P wave gets blocked. After the block, the PR interval resets and goes back to being relatively small. The other type of second degree AV block is Mobitz type 2. In Mobitz type 2, the PR interval of each beat is fixed, and randomly a QRS or more will drop out. Both of these are examples of Mobitz type 2 second degree AV block. In both cases, the PR interval of all the conducted beats remains the same. Obviously, in the first case, there's only one P wave that gets dropped out of 4. In the second case, there are 3 that get dropped out of 5. So the severity of this condition can vary, but in both cases, the PR interval is remaining fixed when it is conducted. So for second degree AV block, there's Mobitz type 1, where the PR interval is prolonging. And there's Mobitz type 2, where the PR interval is fixed and beats are dropped randomly. So this is a summary of what most people are taught about heart block in medical school. Many people are also taught that the things on the top half of this page, meaning first degree AV delay and Mobitz type 1 second degree AV block, also known as Wenckebach, are not usually very serious or life-threatening and usually don't need pacemakers. Whereas the things on the bottom half of this page, meaning Mobitz type 2 second degree AV block and third degree AV block, are more serious and often do need pacemakers. That tends to be true, but I think it's important to understand why. Remember that the electrical activity in the heart normally goes from sinus node to AV node, down the His bundle, and to the Purkinje system. As you may remember, the AV node and the sinus node are both innervated by sympathetic and parasympathetic fibers, whereas the bundle of His and the Purkinje system are not. What that means is that conduction through the AV node is sensitive to vagal tone, whereas conduction through the His bundle is not sensitive to vagal tone. First degree AV delay and Mobitz type 1 second degree AV block, or Wenckebach, represent delayed conduction through the AV node that is very likely to be due to increased vagal tone. The prolongation of the PR interval is our clue that the site of block is at the AV node and therefore mostly about vagal tone. On the other hand, in second degree Mobitz type 2 or in complete heart block, third degree AV block, the conduction through the AV node when it does occur is normal. The problem is not at the level of the AV node. The problem is below that in the His Purkinje system. And because the His Purkinje system is not innervated by vagal fibers, any conduction problems in the His Purkinje system indicate intrinsic disease within the His Purkinje system. So most of the time when we see a patient with first degree AV delay or Wenckebach, it's because they're in a state of high vagal tone. Often they are sedated in the ICU, they can be sleeping, they might have an event happening that's an excessive vagal stimulus like coughing, suctioning, bronchoscopy, vomiting. And usually when those vagal stimuli resolve, the patient's AV nodal conduction will also improve. On the other hand, with Mobitz type 2 second degree AV block or complete AV block, there's an inherent problem with the conduction system, and specifically in the His Purkinje system. We can't fix that by changing the state of vagal tone of the patient, and so almost always patients who have these rhythms will need an external electrical support or backup to their conduction system, which is a pacemaker. One final point that this physiology helps to illustrate is the special case of 2-to-1 AV block. 2-to-1 AV block is a special case because just based on a single strip alone of 2-to-1 AV block, it's not possible to know whether it's Mobitz type 1 second degree or Mobitz type 2 second degree. You know it's not complete AV block, and you know it's not first degree AV delay, but you can't distinguish the types of second degree because there just aren't enough heartbeats, or there isn't enough time to be able to tell. However, if you understand the physiology of what's happening with the AV node in the His-Purkinje system, it becomes a little easier to clarify what's going on with 2-to-1 AV block. If a patient starts off with normal conduction and then undergoes a bronchoscopy and develops 2-to-1 AV block, it's probably due to the increased vagal stimulation from the procedure, and therefore it's most likely representative of Mobitz type 1 physiology. Similarly, if a patient has 2-to-1 AV block and you increase their sympathetic tone, for example, by getting them to exercise, and their heart rate increases and their block gets better, then that's an indicator that it's primarily about vagal tone and function of the AV node, and therefore Mobitz type 1. On the other hand, if they're in 2-to-1 AV block, you get them to exercise and their block does not get better, then that indicates that even by changing their state of vagal tone, you cannot improve their heart block. Therefore, that type of 2-to-1 AV block is most likely to be Mobitz type 2. So to summarize, there are 3 degrees of AV block. First degree, which is really AV delay and not AV block. Second degree and third degree. In first degree AV delay, there's no block at all. In third degree AV block, there's complete AV dissociation, meaning nothing is getting through and there's more A's than V's. That can make the ECG look a little tricky sometimes. And in second degree AV block, some of the atrial complexes are being blocked, but not all of them. When we think about the types of second degree, there's Mobitz type 1, in which the PR interval gradually prolongs, and there's Mobitz type 2, in which the PR interval is fixed and beats are dropped randomly. And the underlying physiology for this that explains this is that the AV node is sensitive to sympathetic and parasympathetic fibers, whereas the His-Purkinje system is not. So first degree AV delay and Mobitz type 1 heart block, Mobitz type 1 second degree heart block, represent slowed AV nodal conduction due to increased vagal tone, and therefore are usually reversible when the vagal tone issue is fixed. On the other hand, Mobitz type 2 second degree heart block and third degree AV block indicate conduction disease in the His-Purkinje system, which is not something that can be fixed by adjusting the state of vagal tone, and therefore these patients will often need pacemakers. Thanks guys, hope this has been helpful. Click subscribe to be notified of my new videos whenever I post them.